Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 33 of the OBGYN podcast. This is the monthly checkup for May 2018, and to join me today, I have Dr. Ballas once again. Welcome back, Jerry.
Hello, glad to be back.
So today, I think we have a couple of interesting papers, and they're right up Dr. Ballas' alley, I think, so I think we're going to have a good time today. The first one is actually from the National Center for Health Statistics, the Division of Vital Statistics, and it is the birth data for 2017. It is provisional. I guess they only have 99.93% of all the births recorded, so they're still working on 100%. But it has some really interesting trends, which I think are going to have some important effects for the United States. And also, I think we can talk about the contributors to them, so it should be interesting. So I'm going to just hit the top line thing, and then we can stop and talk about that. The big finding is that, again, this year, the total number of births and also the birth rate, which we'll get to in a second, were both down, again, by about 2% or 3%, depending on which one you're talking at. And the two of them, that is the lowest rate for the United States in 30 years since 1987. So we have been going down and down and down over the last 30 years, and we're still going down. And I think that is it's a worrisome trend for a couple of reasons. But why don't we stop there? And Dr. Ballas, what did you think when you saw that?
Well, I remember the headlines from about a week or two ago when this was initially released, and kind of the doom and gloom. You know, is this the end of America as we know it? We're gonna kind of fade away. I think it really reflects what we see as obstetricians on the ground as to which way we are pushing pregnancy this day and age. We are getting older women delaying childbearing, families in general deciding to delay. We have a lot of economic pressures where having a child now is really a tough business decision for families. You have people already burdened with student debt, not finding a well-paying job, insurance, etc. Plus, you have more people looking for careers and wanting to delay fertility. And what we're finding now is older folks are not as fertile. You don't have as much time to have many kids. And so, to me, this is kind of a logical trend, given what I see almost on a day-to-day basis as maternal-fetal medicine.
Yeah, I would say that we see the same things as Stony Brook. The number of young women is going down, number of older women is going up. And you're absolutely right. You know, if you start a family at 35, well, you only have maybe 5, if you're lucky, 10 years to, have some kids. So you're, by nature, going to have less. You know, if you start at 20, you have plenty of time to have 3 or 4 kids if that's what you want to do.
Yeah, it was interesting. And the data kind of backed that up. So the overall decrease was predominantly in the women under 40, whereas over 40, we actually had a rise in birth rates, which was just again goes along with the trend. Plus, which I think is a good thing, we have that really sharp decline in the teenage pregnancy, less than 20. And so, biologically speaking, the most fertile time period amongst us are now really being addressed as less than 20, stamp out any pregnancy, between 20 and 35, focus on career or focus on lifestyle, and then after 35, even 40, is when it's becoming more and more of a trend to try, even for the first time, to have a kid.
Absolutely. And we definitely see the same thing. Even the women who are younger in their 20s or early 20s, we find them only having 1 or 2, and part of that actually I think is better birth control. Part of that is economics. With the rise of the long-acting reversible contraception, like the Mirena, which is very popular now, these women are much better able to really control their fertility, which is, so I think it's a lot of different factors going on together. But I wanted to get into a couple more numbers. You mentioned a few, but they do mention 2 different statistics, and I think they're interesting, so I want to kind of explain them a little bit. The first one is the general fertility rate. I believe that's what it's called. Yep. And that is just a straight number of births per women 15 to 44. So that's, they give it as an X per 1,000. And so for 2017, that was 60.2 births per 1,000 women in that reproductive age, which was down 3%, as we already mentioned. And the other one, which is actually a little bit more interesting, is the total fertility rate. And that is actually the number of predicted live births per 1,000 women. And the way they do that is they look at each cohort and they say, okay, if a woman was able to go from 15 to 49 and live through that entire range and have the number of children that each one of those ranges had, what would that predicted number of births be? And so that number for 2017 was 1,764.5, and we know from other studies and around the world that the rate that we need to have to replace or replenish our population on a generational basis is 2,100. So we have for a number of years now, but again this year, down below that replacement rate, which means that the only way that we keep our population up in the United States is through immigration.
Which, we're going to wade into all sorts of waters with this. I think these numbers, with the way our immigration policy is going right now and the way our current political system is seeing immigration, then these numbers have nowhere to go but down. I mean, that's just the bottom line in terms of actual numbers of replenishment, but also contribution to the birth rate. And I would not be shocked if 1, 2, 3 years from now, these same statistics continue to show these large drops, mainly because people aren't either coming here, and if they are coming here, they're also thinking twice about whether to establish roots and even try to have families here. And I think it's economic as well. So the interesting part of both those statistics is that they make a point to say this is the single largest drop since 2010. And in some ways, I think that's an underlying symptom of the underlying economy. Now, in 2010, we were still digging ourselves out from a huge macro crisis of 2008. So you expect to see some changes in fertility and so forth with kind of big economic shifts. But now, despite this kind of roaring, quote unquote, economy and low unemployment rate, there is still a huge swath of underemployment and lack of stability in the employment market that is, some economists are saying, is reaching a boiling point as well, right under the surface, despite all the great stock numbers and, superficial unemployment rate numbers. So I think it's another kind of multi-layered part of this argument is what is kind of driving the decision of otherwise young, healthy, fertile people to not go through with childbearing.
Yeah, I mean, if we could get into the whole politics and economics of immigration and what's going on, but I think that it would be a whole different episode, and two, we'd probably piss some people off. So we'll avoid that landmine for the moment.
Right.
But it's certainly, I mean, you can just look at Germany and other places in Europe, and they're having this a worse problem. They're further along this path than we are. And there's a lot of attention being paid to how do we get, quote unquote, the right immigrants. And again, I don't want to step on landmines, but there is a drive there because I understand that if they don't get immigration into those countries, then they're going to have issues. And I'm going to save those issues for the end of the conversation here. So then to go into the age brackets, and you already went into this a little bit, but there's some really astounding numbers in here. As you said, the teen rate is down 7% year over year, which is huge. But there's some other numbers that are even crazier. In the last 10 years, the teen rate is down 55%. And in the last 17 years, the teen rate is down 70%. I mean, that's just astounding. That's huge.
I absolutely agree. And it's, I think it's not so much it's always the first pregnancy or first birth in a woman under 20 that kind of gets the most press, obviously, because that's a big thing. But I think what's forgotten is that earlier childbearing usually leads to further childbearing. And so now that we're even delaying that first pregnancy or birth, to be accurate, then we've kind of shifted that entire, biologic paradigm. And so again, it's just this shift of modern society where we are controlling fertility much better. We have many methods to control fertility, and we have a different message to younger folks, and we have different economic opportunities to people that in terms of where they should be at certain points in their lives. No, the 24-year-old couple with one or two kids is really on a societal level looking less and less common in certain parts of the country. So again, I got to qualify all this too. This is going to break down again, I think, into certain geographic and socioeconomic strata. But still, the overall big numbers which we see here are leaning towards that occurrence of having children earlier in your 20s is just becoming a more rare occurrence.
Yeah, absolutely. And then to continue that trend down, as you said earlier, 20 to 24 is down 4%, 25 to 29 is down 4%, 30 to 34 down 2%, 35 to 39 down 1%. So you kind of see as the older the population is getting there, the less of the decline. And then, as you mentioned, 40 to 44 is up by 2%. So the only place that was up was in that 40 to 44. And I'll definitely tell you that at Stony Brook, we feel that. Mm-hmm. We see a lot more women in that age group.
Absolutely. Interesting anecdotal story. Running the half marathon yesterday, a woman in front of me and my colleague that were running, both maternal fetal medicine, she had a triplet stroller. So she was running along with triplets, and the back of her shirt said, this is what advanced maternal age looks like. And she's running a marathon with triplets. And even in the course where we were just kind of taking it all in, another woman runs up next to her and says, I'm advanced maternal age too, and I'm trying. And the lady's like, go for it. I'm 41. Just keep at it. And so it was just, it just drives the whole point of this paper home. Like when you sent it and I saw that, I thought it was just an amazing timing to see that.
No, that's funny. And absolutely, I think that is very common. Again, you and I probably have a warped perception somewhat because we're bi-coastal. I'm on one coast, you're on the other. And there's a whole middle part of the country that makes up a lot of this. But I think that the overall trend is exactly what we are experiencing. Maybe not as extreme, but certainly there.
Right.
So get into that. So that's kind of the big takeaways is this change in birth rates. And I want to come back to that at the end and talk about the causes and repercussions. But just to go through the rest of the article, they talk about prenatal care a little bit, and 77.3% of the women got first trimester prenatal care, which is, at one point, I'm not surprised by that number, and I'm also, at the same time, shocked by that number about that it's not higher than that. It's a little depressing.
Right. No, I agree. I was mildly horrified.
Right. And then you look at later no care, and there's a large variation, 4.4% for whites and up to 20% for some of the different ethnic backgrounds. And of course, we all know that goes to socioeconomic status. Here on Long Island, we have a lot of Hispanics who come here for the indigent work that there is, and they, sometimes they don't come until later. Sometimes they don't move here until later in the pregnancy, or they just don't know that they have access through the New York Medicaid program. So we definitely see a lot of that here. And then some people just don't get care until later, for other reasons. And I should state that here in New York, we actually have Medicaid for every pregnant woman. So if you're pregnant, it doesn't matter, you can get health care. And even despite that, we have a lot of women who are late to care. So I can only imagine in some states where they don't have that access, how bad it must be.
Right. And also, again, kind of going, back to current climate, how many aren't going to seek care for fear of having too many questions asked and, the just generalized fear of confronting anyone of authority, they're going to come in, I think, much later in the pregnancy. We're not going to see that yet, but I think we're going to start seeing a delayed wave of that kind of lack of prenatal care again.
Yeah. And I don't want to make this, I don't want to get on my soapbox about the Safe Motherhood Initiative, which I will someday, but I don't want to do it today. But one of the things that bothers me about the SMI, and not that we shouldn't be doing some of their stuff that they recommend, is that it's all the downstream effects that we're trying to handle. What we really should be doing is spending our money on good early prenatal care so we can not even have to deal with some of these hypertensive episodes or VT episodes because we have taken care of the health problems that contribute to it earlier in the pregnancy. And just like most things in America, we don't want to spend the money to solve the heart problem. We want to spend not any money or very little money to, solve the downstream effects that are kind of easier to, not necessarily easier, but in some ways easier to deal with.
Well, I mean, I think obstetric care is a microcosm for healthcare in the United States in general. Talk to anybody about preventative care, and you'll get an eye roll and a whole, speech about, people having the self-control to not be obese, or they have their choices to not eat those French fries. So, how much can we actually pour into preventive care to keep people healthy? I mean, preventive care in our field is prenatal care. And I think a lot of times people just kind of focus on the last 10 minutes of pregnancy, which is the literal kind of delivery and new baby part of it, that the earliest of prenatal care, which I agree with you, is by far the most, critical to have a population-wide effect on outcomes, is oftentimes overlooked because it just isn't that hallmark part of pregnancy that anybody really on a societal level thinks about much.
Yeah, it's not sexy. That's really what the issue is.
No, you don't get cute 3D pictures, and there's no strip mall ultrasound places, to give you cute, keepsake pictures of your 8-week fetal pole.
Yeah, no, it's true. And I think, the other issue, like I said, New York State has this Medicaid program for women who are pregnant, but again, you have to get into that and get registered and all that stuff. If everyone just had, healthcare to begin with, that barrier to early access would be gone. And again, now we're getting into more landmines.
Oh,
but
you get me warmed up.
So, yeah, anyway, I'm going to move on from that. I think you can all see where we're going with that. There's 3 more things they have in here. The next one is cesarean delivery rate. The overall rate actually increased from 31.9 to 32%, and all of that was really driven by an increase in low risk, which is the single nulliparous vertex term deliveries, and that went from 25.7% to 26%. And actually, a lot of that increase was actually driven in Hispanic women, which I found interesting. But what this did is reverse a trend. For the last 3 years, we've actually been going down. Actually, 2009 was kind of the high watermark, and it's been down or steady since then, except for this year where we have a tick up. And it kind of goes along with the preterm birth and the low birth weight, but I was really kind of scratching my head about why we're seeing that uptick. Now, it is a small uptick, so maybe it's really more of just a plateau, but it's still, is that really the natural floor for our C-section rate, or can we do better than that?
No, I think, honestly, of the numbers, that one I took kind of as a possible blip, and I think the jury is still out. And I agree, when you see an uptick in preterm deliveries, you have to wonder if there was less tolerance of a labor course. And if you see an uptick in older women, the other thing I don't have data here on is how much of these were IVF pregnancies,
It's a good point.
And so, the definition of high risk C-section doesn't always jive depending on your local standard of care with the actual, what they say is a low risk cesarean delivery, if that makes sense. There are plenty of patients, I guess it's the level of anecdote, that will say I had IVF done. This is my one-shot pregnancy, and I want to minimize what's going to happen. And so they may not necessarily elect for a elective cesarean delivery, but they're also going to not deal with labor or have their physician deal with labor as well as most would, if that makes any sense.
No, absolutely. I mean, there's just less tolerance for, any kind of
potential poor
uncertainty
outcome.
in labor.
Right. And then I don't have the other part of this data. Again, we're focusing on babies, birth rates, and so forth. In terms of maternal outcomes, this is a completely different database. But I don't have overall maternal outcomes to these pregnancies either. And so that's another kind of factor when looking at these kind of vital statistics that I always like to think about, even though I rarely have such complete data as we do with baby birth certificates.
Right. And then moving on to the last two, I kind of already mentioned the preterm birth rate was up again 30 in a row. Most of that was due to late preterm birth, so that 34 to 36 weeks. And almost all of that was in Black and Hispanic women, which again goes with the cesarean rate increasing in the Hispanic women as well. So this seems to be all kind of tied together there somehow. I think that without drilling down further, it's kind of hard to suss out why that is, and it could just be a blip. It's possible. But it's certainly something to think about, especially that a lot of it's being driven in the Hispanic population, and I wonder why that is. Is it an increase in health literacy? Because we definitely, a lot of the women I see who are better, well educated and whatnot, sometimes they're the ones who demand a C-section for whatever the case may be, or more likely to think it's okay. Of course, some of them the opposite way. They don't want a C-section no matter what, but some of that's in there. And is maybe the Hispanic population becoming more health literate? I'm not really sure. What do you think, Jerry?
I mean, there's two ways to look at the health literacy part of it. There's also the Hispanic patients that, at least my experience at Baylor and even now here in San Diego, is the Hispanic patient looking not to have the cesarean delivery again and seeking out the vaginal birth after C-section. And so I think that sometimes balances out the other side of the spectrum of, very few Hispanic patients, my experience, would look for or even think, cesarean delivery, even, for the first or even for a repeat as right. often as my other patient populations. So yeah, that's the tough part about these kind of yearly big data sets that come out, is sometimes you step back and have to look at the kind of long game. And then also with the preterm birth rate, maybe I just didn't look at it closely enough. Were these all singleton preterms? Because I didn't see that specifically
I don't think it
teased
says that.
out. Yeah, so that's just one other piece of the puzzle. Whenever I look at preterm birth rates or reduction of preterm birth rates and so forth, I always like to separate it out between multiples and singletons. Because the multiples can definitely skew your numbers earlier.
Right. So, and again, it's not huge changes, so
right.
It could just be a blip. It could be something else that's really affecting the numbers, and we don't have the data really to tell that.
Right. No, but I think the overall, the biggest, takeaway from the overall decline we've been seeing, and this report in particular, does point to an overall kind of change in the family structure or the support of families, which I guess kind of dovetails into our next paper when we start talking about it. But, what are the societal expectations of a family between the ages of 20 and 30 or 35 these days?
Yeah, fair enough. So I think to bring it all back around, what are the effects of long-term decrease in birth weight? And, Europe has been seeing a lot of this already. And I can put a link in the show notes to some of the different, places that are talking about it. But they're really seeing a large economic part of it. Japan especially is seeing this, where the number of elderly is going up and the number of young who are contributing to the pension system are going down. And so they're really having a crisis of how do we support all of these people who are living longer with less of a tax base. And then also, what do we do for employment? And this is really what I was talking about before, where the increase in immigration and generally, the people who are left in these people who are left here tend to be more educated, and they're having the higher jobs, and you need someone to fill all the necessarily the lower education jobs, and that's where the immigration, especially from some of the poorer areas in the world, really is driving that. In some places, treat their immigrants better than others. The U.S. historically has been one of the people who treat our immigrants relatively well. But it's how do we deal with this net decrease in population? And I should say that over the last few years, even though immigration has slowed in the U.S. Since probably the financial crisis, even with the immigrants we have coming in, we're still not getting above replacement rate. Right? So you put that out another 10 or 20 or 30 years, and I think, there's probably going to be a big crisis in the United States as well as the rest of Europe and developed countries unless we do something to correct that. And what that is, I mean, there's smart people who argue at this all the time, and so I'm not going to try to interject. But like preventative care, preventive medicine, if we don't do something now, we'll be dealing with the aftershocks from this, and we will spend a lot more money and get a lot less benefit out of that.
Right, and I think the biggest danger are the safety nets that we've built as a kind of liberal democracy, as a civil society. We've really grown used to the background safety net programs that are around to aid with the elderly, assist with the extremely young, but we have not historically focused on the well-being of the middle population, anywhere between 20 to 50 years old. We just never have. And I think that's, we can wade into the, as a single payer system help with evening that out? Possibly. Is automation helping with that? Is that part of the drive towards automation is, compensating for fewer workers? I mean, that's a hard sell right there, because if you have too much automation, who's going to buy what you're making? Mm-hmm. There's the other end of the market system. And so there's going to be, they used to worry about the population bomb. Well, this is almost like the population implosion in a way. How do you fill the middle, which historically has been the driver for developed countries' economic engines?
No, I mean, absolutely. And what I want to kind of come into that now is why, because I think it kind of goes into it, is why is this going down at all? Like, what is really driving that? And I think that you kind of said a little bit of already is the economics factors, right? If you mm-hmm. don't know that if you don't have a good job, first of all, maybe you can't afford to have a child. But even thinking, you're saying, well, my dad had a job, whose dad had a job, whose dad had a job, and mother and mother and mother, if you go back a couple of generations, fine. But I don't know that my kid's going to have a job. So why am I going to have 5 kids? I don't know that they're all going to be gainfully employed, especially these days. This couple had to kick their 30-year-old son out of their house who wouldn't leave, right? So, I mean, and that's a lot of that is due to the fact that he probably never had a good job, and where's he going to live? How's he going to afford to live? And that's hard. And then the other side of that is if you are successful, well, it takes 10, 15 years to become successful. And in the U.S. and Japan actually have a similar problem, is that if you want to be successful, you can't take any time off. Because that's it. Once you fall off the ladder, it's hard to get back up on where you were before. You're starting down a few rungs, and you got to climb back up, and that's difficult. Especially if you're not working the 100-hour weeks because you're trying to care for your child, and that's something we're going to come to in a minute. But all of those factors, the economic uncertainty for yourself, for your offspring, and then also what you have to put into your job just to keep that, those are all challenges, and some of it's probably logical, you're thinking about it, and some of it's just felt. You just feel that insecurity, and it makes it hard to expand your family or start one at all.
No, and for all the examples we have of kind of the quote unquote hardworking, 100-hour a week and economic, powerhouses that are showing these horrible declines in population, you also do have countries that do focus on family leave and care and focusing on the village as the unit to raise a family. And I think that's a huge part of our problem in this country, is that, and it's coming home to roost, is that we do not support young families in our economic system. We just do not. We really have this kind of, lace up your bootstraps, deliver the baby, figure it out and get to work kind of mentality that is not sustainable. And we're seeing that. And I honestly think a huge part of our drive in terms of this backwards population growth is this lack of support for young families.
Yeah, absolutely. And we see that in the women that we deliver. The in general, the less educated you are, the less of those well-paying jobs you have, the less you actually have parental leave at all, which is we're going to talk about in 2 seconds. And we see women who at 2 to 3 weeks. I mean, we have a lot of housekeepers I used to see when I worked in one part of the island, and that's they only get paid if they go clean houses. And so 2 weeks after they delivered, they were out cleaning houses because if they didn't do that, they couldn't buy food for the baby or for themselves or clothes or whatever it was. And so what we're going to talk about in a second is actually parental leave among OBGYN residents. And, a lot of them get 6 weeks, which we'll get to. But in some places and for some people, 6 weeks would be amazing, right? And we're going to talk about probably maybe how bad 6 weeks is. But we have to remember that even though it's not ideal what we think for OBGYN residents or for doctors in general, there's still a whole population of people in this country who don't even have that at all, which we might consider the bare minimum. So that's, I don't know, it's a difficult nut to crack.
No, I think, my reaction when I read 6 weeks, and I still think that's a joke, and I'll be branded as kind of, this ultra liberal Swiss in hiding kind of person for recommending even longer family medical leave. But I think we do have now enough studied models and enough both countrywide as well as individual companies and large corporations that focus on medical leave to show the benefits on both an individual level as well as a productivity level, that extending medical leave is not, it goes against the knee-jerk thinking that, the further somebody's out of work, the less productive they are. But if you stick back and look at the long game, that's not necessarily the case.
Agreed. And so the paper, we'll stop just referencing it and we'll actually talk about it. But the paper we're talking about is from the Gray Journal. I believe it was in the last month in May. It was a pregnancy and parental leave among obstetrics and gynecology residents, results of a nationwide survey of program directors. And what they did is exactly what they said, is they surveyed program directors in OBGYN. 65% of all the programs in the U.S. responded, 57% were university, 31% were community, and 3% were military. And then they asked them, how much do they have a formal policy? If they did, how much time did the childbearing resident get? Or if they were a non-childbearing resident, how much did they get? And they asked them, despite all that, or including all that, do you think that's good or bad? And do you think having a baby is good or bad for the residents? And so we'll go through those data points right now. Interestingly, 64% of the respondents, so the program directors, were women. 66.8% of the respondents had children. 35.6% of those had them during training, which I thought was really a high number. And then after that number, 82% of all the people who responded had a formal leave policy, and 55% had them for non-childbearing partners as well. So I want to stop there and talk about the formal leave policy and how important having a formal leave policy is, or a formal policy for almost anything, because it kind of enforces your, what's what I'm looking for, standardization. So everyone gets the same thing. There's no negotiating. You don't have to say, I'll do this and I'll do this and I'll get this. No, if it's 6 weeks, everyone gets 6 weeks, and that's your standard. And that really does make a difference as far as employees in general, but for residents as well, knowing that there's no stress about trying to figure out how much time you have and can you get it, is it okay? You know that if you deliver, you're going to get 6 weeks, and then you can just plan for that. And that's really helpful, I think.
Well, and to take it one step back, to put this into context, in 2016, it was ACOG that really kind of, as much as a society can do, put their foot down with their policy statement and actually outlined a couple of numbers, which the 6 weeks was one of them. 6 weeks leave for, we'll call it family medical leave, both kind of encompassing maternal and paternal, or, non-childbearing. And the other caveat to that, which I think is very interesting, we have to bring up, it's 6 weeks off without the expectation of making up that time, which includes call. And that's what was kind of a running theme in a lot of the reasons for not having a policy, or one of the hardships for having a policy, was this seemingly insurmountable inability to figure out how to cover calls and time for the person that's away without penalizing the person for when they come back, and pretty much, giving them a third more calls suddenly because they have to make up all that time. So I think that's kind of the what got the ball rolling. And going back to what you're saying about, policies and so forth, there once you put something like this into effect, there's definitely going to be a cohort of people that say, great, if we make a policy like that, guess what? Somebody's going to plan to have a baby in residency because we told them they can have 6 weeks. And I mean, that sounds insane that people would say, oh, somebody's dying to have a baby in residency because it's not hard enough, but they get this luxurious 6 weeks of leave. And so I honestly think that's one of the hangups to actually writing down a policy, because otherwise, from program to program, you can kind of make it up as you go along, piecemeal together sick days, vacation time, and in a way, it acts as a deterrent. I mean, I'm kind of cynical. Yeah,
I agree with you.
And we're actually, you and I are in I think a cohort of a generation that's definitely coming around to the idea of having children during residency. And still, there is a certain amount of trepidation about acknowledging it.
I mean, listen, you and I, but we both have children. Now, obviously, we were the non-childbearing resident.
But my wife was the childbearing resident, and she, being a pediatrician, eventually a child neurologist, she understood the importance of, at minimum, the first 3 months postpartum, biologically, socially, etc. Right? So we had Violet right at the end of Regina's second year of residency, right in the middle of June. Perfect. She could fudge a half a month of, research so that didn't come off her ledger. But then to begin the fellowship portion of it, they took all her vacations, sick time, and then a month and a half was unpaid. The only way she could do that is that she had a faculty husband that could absorb that cost, and even then, she's not graduating till September because she is making up every one of those days.
Right, and that is one of the things they talk about at the end of this paper, is that right now we have a time-based residency and fellowships as opposed to a competency-based, which is what they really do in most of Europe. And of course, that's complicated as well, but just because you miss 6 weeks or you miss 12 weeks even, doesn't really mean that you can't learn everything you need to graduate in time. I mean, I'll tell you that it's hard pressed to find 6 or 12 weeks during your residency where that's going to make or break your progression as a OBGYN.
What my wife is going to be doing from July through September it's, in my opinion, asinine. It really is. It's just literally, like you said, making up these mythical time-based benchmarks that, quite honestly, were created in a time, or at least maybe not literally in the time, but created in the vein of what classic residency was invented for. Unmarried, young males who were forbidden to get married or have kids during their apprenticeship in the turn of the century in 1900. And quite honestly, that is what a huge chunk of our residency training is still based on. And you could read I'm jumping ahead, and I circled it twice. I love the quote from one of the residency program directors on table 3. Residents should be focused on residency during training. Having children whether they are the childbearing parent or not, is a distraction. And the best clinicians are focused on medicine. It also creates great financial pressure. I recommend my residents not start families while in residency because the burden is quite high. And I give this program director credit for, at least in an anonymous survey, writing down, which I believe many more people think, but weren't going to write down.
No, I agree. One of the things that really struck me was that 72% of the program directors believe that the childbearing resident should have greater than 6 weeks, but 50% of them only took 4 weeks.
Right.
Right. But there's a change there in attitudes. You can see it kind of happening, but the fact that they really believe more than 6 weeks, but they're only given 4 weeks, that tells you right there.
Right. And I'm not one to, minimize the administrative economic pressures of these hospitals to run on a shoestring budget while, paying the residents and still getting patients seen in an economic way. There is absolutely an economic burden to covering, staff when they are away from work. But it also is something that can be planned for. And if you change the paradigm of how your system runs, who sees, how work is doled out, expectations, so forth, you can find a lot of the ability to cover by changing the paradigm of how you run your training program. One example is just with some OBGYN programs specifically, they go to the ends of the earth to offer all sorts of elective type rotations, all sorts of subspecialty types rotations for their residents, for the experience part of it, which is fantastic. But the overwhelming bulk of the work is obstetrics, gynecology, and oncology. And if you focus on, those types of, where the work is, then you can create coverage schemes that anticipate a resident not being available. You always have to plan for a resident not being around. That's just logic. But sometimes some programs get spread so thin that you don't know where a quarter of your residents are because they're squirreled away in some sort of, smaller elective type of place. Anyway, I'm getting into the weeds. You can tell I've kind of thought about this a lot. But
you're not wrong. At Stony Brook, we have off rotations. Like I think it's one resident per year is doing something that is not a core activity.
Right.
And they get pulled. When somebody's out, whether it be from pregnancy or it be from other childcare or someone their family experiences a death.
Of course.
Like we pull someone to cover that because we understand that those type of events don't stop when you become a resident. And just because you're a resident doesn't mean that you can't participate in your life. Right? A couple of things I wanted to bring up is I'm a big proponent of 12 weeks. One of my friends had a baby, 7 years ago now, 6-7 years ago. And she said after her maternity leave, she said calling it maternity leave is a joke because it's not about maternal at all. It's not about the mom. It's about keeping a baby alive. So it really should be called, child care or something care, right? But it's not maternity care.
No, and the fact they call it leave, maternity leave, like maternity leave makes it sound like you are, just kind of being pampered, eating bonbons and bonding with your kid over television. Like it is the worst misconception of what postpartum care is.
It's really newborn leave. That's really what it is.
Mm-hmm. It's the fourth. I'll sorry to interrupt, but it's actually the fourth trimester, and I think ACOG did a great thing these past few months, coming out. And maybe we can make this a journal club or a committee opinion or a next monthly checkup. But the fourth trimester committee opinion that they came out with, that is a practice-based committee opinion for us as providers. But I think it dovetails with how we should treat ourselves as well. And that fourth trimester, if you make it about that, these babies are still fetal. They are still vulnerable fetuses that need 24/7 attention and care.
Right. And we know that the amount of good care they get during those first 3 months affects them the rest of their life.
Absolutely.
So why are we not investing more in that? So one of the things at Stony Brook that we do is basically everyone gets 12 weeks if they want it. And we encourage people to take, and this is not for residents, this is for faculty. Mm-hmm. But if you want to take 12 weeks, you take 12 weeks. We'll cover the call. We'll cover it all. Because eventually we know we'll all be in that situation where we need someone to cover us. May not be for a baby, maybe something else. But, we are committed to each other to say we believe that 12 weeks is the right amount of time. And, and there are some people who don't want 12 weeks because they have someone else staying at home with them and they don't want to use all their sick time. And that's fine. But if they want to take 12 weeks, they can have 12 weeks. And we feel very strongly about that.
And I think in residency programs, is there a threshold for time missed affecting your training? I believe there is. I think 6 weeks is definitely not. I mean, 6 weeks, come on. I mean, I can, out of 4 years of residency, I can add up 6 weeks where, I could have maybe done more, real stuff. But, I think 6 is 12. I don't know. Are we starting to stretch the limits of competency? I just don't know. But I also don't think that you're suddenly going to be graduating somebody that drops babies at a perineum or don't know how to close fascia. I think that's a ridiculous sentiment that, again, goes back to this mythical apprenticeship, holier than thou feeling that from July 1 until June 30th of whatever how many years, you are ours.
Right. No, I mean, I think you would agree that most programs are OB heavy, and especially in today's world of declining hysterectomy rates, that you really need that gynecology time to be able to get at least semi-proficient in those major surgeries. That if you're going to cut time out, you can easily lose a few weeks from your OB because most places do. I don't even know 20 to 20 plus weeks of OB every year. Like, there's plenty of time to learn how to do all that OB stuff. I would say you're cutting out elective, right? And the OB stuff, a little bit of OB is probably not going to harm someone's competency. Now, again, if you lose an entire year's worth of OB rotations, well, that's a different story. But a couple of weeks is not going to make a difference.
I mean, I'm more of I'm actually, more of an extremist. I think either we need to, I think as a profession, I mean, this goes down a whole other rabbit hole, but I think tracking is going to be one of the ways we go to address that very issue. Is it possible 20 years from now, given the way our surgical and medical treatments and so forth are going for gynecologic disorders, like, is a program of, we'll use our program of 5 per year in a confined 4-year space, going to have enough to go around to satisfy a general OBGYN? Or are we going to really have to start thinking about, here's an obstetrician's track, here's a gynecologist track, and let's either lop off a year or tack on 2 for specialties, for subspecialties.
Right. Well, they're talking about that now.
And I think that's creative, and I think it could address a lot of the life issues that come along with this time in life. I think shift work, as many of its downsides that it has, I think also speaks to a lot of these coverage of calls and so forth that programs get really worried about. If you even out and really try to make the work much more evenly subdivided across all rotations, then it becomes, I think, a lot easier to make up different times or shift people around to cover for things.
Well, I also think that to take it even deeper fundamentally is, what do we use our residents for? Mm-hmm. And do they need to be used that way? Like, is there a different way of picking up slack than just, taking another resident and plugging them in there? And of course, that goes down to how we pay for training in our country, and with the GME and all that stuff. So that, again, that's a whole rabbit hole there. But I will say, before I move on to my last point, because we should finish up, we're running a little long, is Oystein Bergoyev friend of the show, did a couple episodes for us. He had a baby in his training, and he's a resident there in Norway, and he had months off to be with his wife, and then and what they do in Norway, which is interesting, is they both get, I forget how many months, so I'm probably going to say it wrong, but it was multiple months, and if one of them didn't take it, neither one of them got it. So they had to take their time.
Awesome. I mean, that's biology. I mean, that's when we talk about labeling what that time frame should be, nobody would argue what pregnancy is, right? You can pretty much go person to person and ask them, what is pregnancy? And most people have an understanding of what pregnancy is and kind of the do's and don'ts and what to expect. But the reason I don't understand why postpartum period isn't as easily recognizable. And I think that's the big obstacle we have to overcome as a specialty ourselves. I mean, how can we, in good consciousness, go and try to provide this care for women and we don't give it to ourselves? I mean, that's just, there's always been that paradox in my mind. I mean, the way we treat ourselves and then to tell people to go treat others differently, I think is a huge shortcoming in our profession, even amongst our residents.
Get our own house in order.
Yeah, I mean, I even saw firsthand some older attendings, telling stories of how they delivered on a Friday and were back on a Monday as a kind of a story of, empowerment. But this generation that's not how it's going to come across,
Right. Well, it's meant to be impressive, but it's not impressive.
Exactly. And it is. So,
yeah.
Yeah.
So the last thing I really wanted to touch on was really the non-childbearing partner. And I did a little bit with Oystein, but again, I don't know what you had, Jerry. You can tell me, but for me, my wife and I were in the same private practice, so it was a little rough. And I had 2 weeks, but during those 2 weeks, I had to do my call and her call. So I wasn't in the office, but I was doing 2 or 3 calls a week to cover the hospital. And so it wasn't, I was, those 24-hour calls. So I was mostly exhausted. I was exhausted with the baby. I was exhausted from doing call. My wife was left alone for 24 hours with the baby. It was not ideal. And again, there are people who have it far worse than that, so I don't want to, complain too loudly. But really, I mean, we can do better than that.
No, and so for me, I had, so when I emailed my HR person, was told flat out that they do not have a quote unquote paternity leave policy. So basically it's adding up my sick time, my vacation time. I can take now, family medical leave. You can everywhere you're legally allowed to take 12 weeks. Doesn't mean you get paid for it, right? And so when I was able to put together my sick time, vacation time, I came out to, and luckily she was born mid-June, which incorporated the 4th of July weekend, at some point in there. So those were days I didn't have to, count towards my stuff. But then on top of that, I had amazing coworkers that looked at the grid, looked at our shifts, and cobbled together another week for me that was kind of off the books. So I was officially back at a certain day, but they had rearranged the schedule in such a way where they didn't need me for a whole other week. And so I ended up with 5 solid weeks.
That's fantastic.
Which was great, completely not in the hospital, barely thinking of anything. Now, obviously, I'm an email addict, so I would still answer things and, read papers and, help residents, blah, 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 but definitely nothing expected, no calls or anything. And that was great. I mean, that was just absolutely amazing. And I try, so going back to, when you were mentioning some of our patients and so forth in terms of leave, what I've also noticed though is, a lot of my patients, the state-funded patients, are patients that work paycheck to paycheck, don't get paid. They tend to have a mini village helping them in some configuration, whether it be a relative or a woman in the apartment building complex, or somebody coming in for. They really embrace the village raising a child. I call it the third shift. I tell all my residents, anybody that's thinking childhood or having kids, I always talk about the third shift. You have to have some component to fill that third shift of a day to keep your sanity and to help raise that kid. And it can be any configuration. It can be daycare. It can be a nanny. It can be a relative. But it has to be somebody for a discrete period of time, giving both parents some break for that third shift. And even if that person, the example used before, going back to work within 2 weeks, in my experience, there's somebody there, some sort of safety network that is helping them out. And on the flip side, I almost find that us being the above average earners and well-educated and hardworking tend to not pay attention to that and really tend to take it all on our own and have this kind of mentality that we must support immediately, economically, and get back to work as soon as possible. So
I'll also say that we as physicians are more likely to be away from our family and family structure, just because our residencies take us maybe away from our families or whatever it may be, our training. So, at least for us, my wife and I, we have no family anywhere near us.
Right.
And so we're fortunate enough to have a good nanny and to make enough money to pay for that. But, I'd love to have a family member to help out and lean on sometimes, but we just don't have that. So it's a lot of careful arranging between my wife and schedule and my schedule and nanny schedule. And, sometimes it falls apart.
Right. Oh, yeah, absolutely. There's times where, Violet, I have pictures of Violet rounding with me. I mean, that's just classic kind of physician families. And I think after 3 months, I think that's fantastic. Before 3 months, I think there's something biologic, socially, and just absolutely necessary for both parents to be as close and as much time with that kid. 3 months is 3 months is like a light switch. Suddenly the kid's a little human being, like out of nowhere. You're like, who are you? You suddenly look like a little independent person. But until that point, they're just these puddles of goo that just need, 24/7 care. And I think we can do better as a specialty, understanding that within our own residence before we can really make a change in society.
I completely agree. So we managed to talk for a very long time about two, I think, kind of interlinked but very important topics, and we probably could do another hour or 2 hours on this, but we'll save you all from that. But I think we really opened up some good topics for thought. I hope that we got you all thinking about these topics, and especially if you are in a residency program, if you're a medical student now, or if you are a program director, I hope that you really think about the pregnancy leave and what you can do in your own place to affect some change on that. And then the other one, for as far as the birth rates, I think that's more just interesting and really makes you think about, as a society, where are we going, where do we put our resources, and how do we affect the change that we want. So I just hope that they really got people thinking on this one. I want to thank Dr. Ballas for being with me as always and contributing his insight to the topics.
Thank you, Joseph, for having me again.
I think that next week I'm finally going to come out with that aneuploidy episode I've been talking about for the last couple months. It's pretty much ready to go, so I'm excited about that. And I got a new journal club coming up, hopefully with some new voices. We're going to talk about a gynecology paper, so I'm excited for you all to hear that. And then hopefully over the summer I got some very interesting things to put out for you, which I think are really going to get people's minds going. So I'll teach you for that. But until we get to that, I want to thank everyone for listening, and we'll see you next time.